The Knee Gurus, the latest research and advice from industry experts for best practice management on knee injuries and pain. Here's your host, Bevan Collis.
Okay, welcome back to the Knee Gurus. I'm your host, Bevan Collis, and this week we're very lucky to have with us PhD certified physiotherapist Timothy Sayers. Timothy has a special interest in knees, and he practices out of Melbourne CBD Clinic in Melbourne. Recently, I was fortunate enough to go to Melbourne to attend a traumatic knee injury course that Tim and his colleagues were running, and I was super impressed with his clinic and the operations there. And also, interestingly, shows how old I am, but when Tim was a student in his final year of university, he actually did a placement with us in Niseko. I guess he had an interest in knees early on in his career, and has since gone on to complete his PhD, I believe, straight from university. That was an unusual path that he took, and followed his interest in knees right through his career, and is now running, I think, one of the top physio clinics in Australia from what I've seen, but certainly in Melbourne. So welcome to the show, Tim.
Thanks very much, Bevan.
It's great to have you on. Can you tell us a little bit about your inspiration for the Melbourne CBD clinic, and what sort of inspired you? It was obviously a huge financial investment for you and your partner, and what was it that sort of made you want to take the plunge to investing that sort of capital into a physio clinic where a lot of people can open with a fold-out table and a Reebok step?
I guess from our perspective, both my business partner and I have been always interested in advancing and I guess improving health outcomes in whatever injury it may be. To give you a bit of a backstory, my background was obviously I did a PhD in knee injuries. I had a clinical interest in I guess biomechanics and sports performance related to ACL injury. I was also teaching at the time and saw a lot of different facilities, both in Melbourne and overseas. I was fortunate enough to go overseas for 2 years to Luxembourg, which is a very small country in the middle of Europe that has an incredible amount of wealth and put a lot of money into the healthcare sector, believe it or not.
All right.
So, and they've actually, people don't know about this much in Australia, but they've actually just invested in one of the biggest biomechanical institutes in probably the world now, with some pretty high-tech equipment there. And so I was exposed to that, and I guess the philosophy of why they invest in such technology, and it's essentially to push the boundaries and understand more about the human body and in some ways trends and understandings of why a certain injury might be prevalent in a certain population. So then I guess that gave me the spark, if you like, to bring that back to Melbourne. And my business partner now is very much interested in sport performance and high performance as well. Comes from a bit of a different background, but collaboratively we said the landscape at the moment of physiotherapy and sports medicine practices is standard, if you like. And that's not so much a bad thing, but I don't think anyone was really pushing the boundaries at the time to really change the way we do things. And it's traditionally been in I guess institutes, so Australian Institute of Sport or Victorian Institute of Sport and the likes, that you would foresee high-tech equipment or sort of, I guess, the pinnacle of sport and rehabilitation. And we just said to ourselves, why not invest in technology that's being used overseas, that's pushing the boundaries and try to invest in that in a I guess a commercial or private practice setting. And so that's essentially what we did in developing our clinic. And I guess to extend on that, we're very curious people in that respect. We both come from research backgrounds, so we try to push the boundaries of what's possible, I guess, with our patients. And we started that journey 5 years ago, which has been really great, because I think we've understood a lot more about how technology and how we can advance and make better informed decisions around our patients' health that we just can't do in the sort of standardized setting, as you mentioned, Bevan, with a Reebok step and a plinth.
Yep. Yep. Awesome. Yeah. Well, we did something very similar in Singapore, and was a big leap. We're probably a couple of years after you, but I know that stress of putting in a huge financial input into a business that's quite pioneering, and you're not quite sure, whether the general public will see the value in it. And you think, oh, people just get convinced by their physio's charisma or their fast talk or whatever, and that's often enough to keep people coming back. How did you find the buy-in from the patient was? Did they understand the value of the technology quickly, do you think, or did they think, wow, I'm not a top level athlete, I don't really need all this stuff? Or how did you find the general public appreciated the level of facilities and technology you have there?
I think we're still working on that, to be honest. I think that's just an evolving process.
Yeah.
At the moment, to give background to it, we have Kaiser equipment, right? So everyone looks at our equipment and goes, oh, you've got Kaiser.
Yes.
But Kaiser and Kaiser are totally different. And so that's the marketing challenge for us, is to get people to understand, I guess, what Kaiser is. And for those that don't know, Kaiser is pneumatic technology, which essentially means it works on a chamber, a cylinder basically, where there's compressed air, and you adjust the resistance down to, some of the machines go down to 100 grams. So you can be very finite with how much load you want to apply to whatever task it is. And the ability then is that it can train power. So you can go from your basic resistance training, slow tempo, up to really powerful athletic-based movements. And that came, or this currently used, and it came out of the States. So it's used routinely in a lot of American professional teams, institutes around the globe in that respect. So from that perspective, I guess a lot more patients are now aware of how our technology is different, but the new patient that comes through would honestly just see this as a piece of gym equipment. Yep. And it's on us to, I guess, educate them around the differences of it. It's a bit easier for us because we tried to make the facility a bit more exciting with its sort of the surrounding space with lights and jerseys and all that kind of visual art to make it a bit more appealing. But yeah, essentially, and that without, the Kaiser gear is sort of one aspect. Technology is another aspect as well that we sort of advocate around and still currently educating patients on. So it's a evolving process, I guess.
Yeah. And as far as that objective measurement technology, I know you got a lot of the valve equipment there, and valves seem to be growing at a rapid rate all over the world at the moment, and they're just sort of moving from the high performance sports teams where they're all of the Premier League and NFL and NBA and pretty much all of the big professional clubs have got the valve equipment, but now there's more and more private physiotherapy clinics bringing in this technology, like the force plates and Nord boards and dynamos and whatnot. Can you tell us a little bit about those different products and how you're using those? I guess there's quite a few. So the force decks are probably the most interesting and high tech product that they have. Are you using those a lot in your clinic, and how are you using them, and what sort of tests are you finding helpful?
So I guess we do use valve equipment. So as you mentioned, we've got force decks, force frame, Nord board, dynamo. So there's a few bits of their gear we don't have. The funny thing though is we're actually about to change equipment. So we've been with Vald, and I think to give them credit, they've done an excellent job of making technology accessible to a lot of clinics across the globe. I think that's the unique competitive advantage they have, essentially, is that they are enabled really quick data capture on an athlete or a regular person post-operatively, whatever it might be, And we've been with them probably for 5 or 6 years now. We're changing because, again, we're trying to push, I guess, the trend of what we want from our high performance side of things and what we want from our daily sort of post-operative patient, you might say. So we're actually changing equipment. Having said that, we routinely use the decks. So the force decks are really a good application for isometric assessment. We routinely would test isometric calf strength. Some of the VALD sort of standardized tests we do a little bit of, which is the isometric mid-thigh pull and the quarter squat isometric tests as well. Counter movement jumps, single leg hopping tests. It's really quite variable depending on the patient, but that would be the standard tests we would use on the force decks. As for the force frame and the Nord board, we used to use the force frame quite a lot, to be honest, for a lot of our hip assessments, but we pretty much refine it now down to hip flexion, hip extension, and for the certain patient that might be more groin or hip pathology, the adduction, abduction. But I'll be honest, we don't tend to do that a lot anymore. And then for Nord board, it's obviously the standard Nordic. I know you can do different types of Nordics that they advise, but we just do the regular Nordic.
Yep. And one of the things that interested me during the course that you said was that the growth of tech into the sort of sports science place has been so rapid that it's a little bit of a mess at the moment, and there's not enough consensus about what tests are appropriate and what data you get from all the tests. Do you want to expand on that thought a little bit and let us know what why you think that and what you sort of see in the future of utilization of this tech and this data?
Sure. Yeah, I think so. Technology is obviously expanding in physiotherapy, sports medicine, sports performance. This whole realm will continue to advance. And sort of, I guess, to give a bit of a history of this, I've been involved with for many years at the university level teaching education to physiotherapists. I now only do that more as a consulting casual role. So I know from an education point of view, they're starting to consider education in technology. The problem is the education sector pretty much like dealing in fact, more or less. So they obviously like a lot of evidence around it. They like papers to show students and I guess maybe even master's level students in physiotherapy around what tests they should be doing, what are the benchmarks. The problem is the reality in clinical practice and the commercial side of things in terms of technology is it's expanding so rapidly. And there's a number of technology devices that I know about that, and I'm sure many others know about, that are actually not on market yet. They're coming to market, which makes it challenging because the research hasn't been done on it. So the problem that I guess on the VALD side of things or the technology in that space where we're talking about isometric tests, counter movement jumps, sort of running speed analysis, is that there's not big controlled data that looks at normative values for different athletes, different sex, different populations. I'm sure that's going to be done in time, but that is the big challenge.
Yeah.
So one of my sort of, I wouldn't say it's a gripe, but I think it's one of the biggest problems we have in physio is that we should be trying to benchmark something, but often it's not. It's often sold as asymmetry alone in a lot of the tests you do. Yet the quality of the way you set up a test is really important. So while there are some normative databases that have been used, and so if you take VALD, for example, they've got a normative data set, right? They take from all their technology around the globe. The problem is a lot of that's not actually quality data because it's not performed in a way that you could confidently say that each Nord board test was done exactly the same way. Each counter movement test was done the same way. It's essentially just big data compiled together to give an idea around what athletes are performing on these tests, which is a start. So that's a good thing, but it's only a very rough estimate of the benchmarks that we need in technology. And so that's, I think, the problem with the current use of it is you'll see clinicians getting technology in their clinic. They put a patient on it. And how do you decide if someone's good enough to go back to sport? How do you decide if it's actually clinically relevant to work on that particular aspect in their rehab? It's a bit open-ended, and that's the problem I think a lot of clinicians have with implementing technology and the way it sits right now. And the fact then that more updates come, more pieces of equipment are available to market. So there's obviously various different companies now that provide something similar to Vold. And there'll be further pieces that I can tell you right now that'll come out with putting insoles into shoes and seeing how you run and jump within a clinic and getting force outputs. There's going to be different wearable devices that come along. AI will explode to provide trends in analysis. It's a rapidly evolving space, and I don't think the research can keep up with it, because research takes a lot of time to perform. It's very much quality driven.
Yeah.
And we know that it's normally about a decade behind clinical practice. So it'll be a while till we get some data on this. So, and I think that's the challenge at the moment.
Sure. And how have you sort of come to the conclusion that the test that you're doing in your clinic, you say you do a lot of isometrics on the force decks, particularly calf, and you use the data for that quite regularly, I guess, with a lot of your tendon issues and whatnot. What's kind of helped you narrow down the tests that you've decided or that you've worked out are the most useful, and worked out the metrics that you use in your clinical decision making in your clinic?
Yeah, so I guess it's worth acknowledging that it's not a big trial or anything like that that's come out to show this is the normative data, but we have tried to collate lots of different, I guess, papers that look at isometrics testing strength of different joints, and they're typically done in a lab-based environment using an isokinetic dynamometer.
Yeah.
And there's also other sort of hip and groin tests that have been done with handheld dynamometers. And we've essentially tried to collate what is a reasonable benchmark, because we wanted something to have as a threshold for assessing our patients in whether it's a calf, a hip, a hamstring, or a quad test. We want to actually benchmark what's appropriate. And there's a little bit of a grey area there, because obviously we're banking off multiple studies and then a bit of our own clinical experience. And we essentially set the threshold then for all these tests, and started to see if they have worked from a bit more of an anecdotal, but a pathway approach that we've put through with a lot of our patients. And it seems to work really well. And I think the calf test, for example, is taken from a lot of that tendon research.
Yep.
It's also, so Alex Natera has some really good stuff, which you may have heard of from I think he's at N-Swiss at the moment, but he works a lot with Vold as well and up in Queensland. And there's a lot on the isometrics being very important with respect to function. So it's all well and good to measure an isokinetic test if you have that capacity. Force decks are good for jumping analysis as well. But the isometric component is actually quite critical to function, because we go through, think about with your jump, landing, running, might be skiing even, a lot of those movements have a foundation of isometric contraction.
Yes.
So while a patient might be able to produce a reasonable amount of force with a concentric, eccentric action, the isometric action is actually in some ways far more valuable and important to their function than getting them to lift really heavy on a leg press or a calf raise, for example. And that's because we're eliciting a motor function, so a neurological base, and then a stiffness component to the collagen and your muscle output force, of the force output of the muscle as well. So that's where we come back to the sort of this benchmarking of assessment being predominantly isometric. And I guess the last component of that, or the reason we do that, is because it's a far easier approach in clinic. So we can easily assess isometric knee extension at 70 degrees on the edge of a plinth or a box with the dynamo, for example. And I think a lot of clinics do that. You can do the calf test in a rack or a squat rack that's pinned appropriately, so you can actually push quite hard against the rack and the force decks below.
Yep.
You can do an isometric squeeze for abduction, adduction, flexion, and extension of the hip. The only one we don't do an isometric that well, because we haven't found a great way for it, is the Nordic. You can use a handheld dyno, but it's just the force application is a bit different, and it will be variable between clinicians. But that's a sort of, guess, the suite of tests that we would use, and the benchmarks that I guess the background of the benchmarks as to why we do it.
Yeah. And as far as those tests and how they tie into some sort of more standardized return to sport testing or landmarks, say for a post-operative ACL, a few years ago, obviously the Melbourne ACL rehabilitation guide was a bit of a breakthrough, and that was a sort of a shift from time-based progression in rehab to objective measurement tests. Can you see a time where that'll be sort of overhauled and there'll be tech measurements that become a little bit more standardized in, say, return to run testing and return to sport testing for, say, post-op ACLs?
Yeah, for sure. I mean, it's coming. It's just a case of, I guess, completing the research as well. And then the controversy of this is you've got different opinions in the people that are involved with not just ACL, but any area as well. So what I might think will definitely be different to another clinician. And so the challenge will be, I guess, a consensus around what's an established level of strength, for example. But that's just one element of your return to sport or return to run for an ACL population. I think it's worth pointing out for us and for listeners that we don't triage a different set of tests, for example, for an ACL that we do for an Achilles or for a hamstring. Sure, they have their independent differences, and we respect the pathology in that respect and the process that it goes through from a time-based healing. But the fundamental movement is the same. So when you go back to run, when you go back to jump, when you go back to sport, nothing changes. The actual fundamentals of human movement are the same.
Yep.
So we actually test a lot of our isometric strength, for example, or our jumping analysis at a same threshold of expectation, if you like, for an ACL, to a hamstring, to an ankle injury, to an Achilles. We just might triage that process at a different time point based off obviously what's happened to the patient.
Yep, that makes a lot of sense. And so have you been developing your own sort of standard results that you require people to achieve for return to sport or return to running?
We do. I mean, it's not a research-based approach. It's more of a clinic-based approach that seems to work pretty well.
Yep.
But as I mentioned before, we have a bunch of strength tests. And I guess the way clinically we think about it is we first have to establish whether there's capacity in the muscle groups that we need to be able to go to running. And this is one of my big sort of areas of interest is I think return to running is far too early in the general population for not just ACL, but for a lot of post-operative conditions.
Oh, really?
And that's coming down to traditionally people have been taught by the orthopedic surgeon, physio, whoever it might be, knees quiet.
12 weeks.
Yeah, 12 weeks, start going back to run, it looks good. If you actually step back and think about that though, just because a knee's quiet doesn't necessarily mean it's ready because you haven't actually prepared it to go back to the function it needs to perform. And so if you think about what is the function it needs to perform with running, it's important to understand the load in running. And so when we go from walking to running, we know a lot of mechanical studies in healthy patients, some really high quality data has been done here to show you just about triple the load in the knee of the tibiofemoral joint. Your muscle load goes substantially higher in the soleus, gastrocnemius, quad, and hip. So the muscles don't just gradually or linearly increase, they actually exponentially increase from just simply walking to a slow jog, like 3 meters, 4 meters a second.
Yeah.
So when we ask our patient to go back to running at 3 months, as the traditional approach has been, you might get away with it because the patient is genetically pretty well adapted to the condition that they've had. So they've actually got reasonable muscle bulk. They might actually have a pretty good running gait that actually doesn't displace a lot of load across the knee. It's actually a pretty shared approach across the hip, knee, and ankle. And you can actually start to accommodate some running without getting into too much trouble.
Yep.
But for what I see, the majority of people that they start running 3 months, they've been told they're clear to go. And I'm sure you've had patients like this. They start to get niggles. So they start to swell as well, goes up and down. Patellofemoral pain starts to come on, goes up and down. And they start to lose some kind of confidence in the knee. And this process might happen over 3 to 6 months. The problem with that, I think, then is you're inviting inflammation into the joint. So then you've got this catabolic process going on within the knee that's pretty slow. And we know that cartilage health long-term in ACLs is not great when you've started to have swelling and pain even 3 to 6 months after surgery, because we have this evolving process going on in the knee that doesn't actually come out typically till 2 to 5 years.
Yeah.
So I think it's important in the early stages. It doesn't change the long-term rehab of something like an ACL injury, but if you can hold off running, that's what I say to a lot of patients, we still get you there in the same time frame, but we ensure that you've got capacity, resilience, and strength within the joint to perform the function that you want to be able to do at 6 to 9 months' time. So we actually have a lot of our patients achieve really high levels of strength in calf, quad, hamstring, hip, no clinical signs, no instability signs, and then graduate their return to running. So not just go for a run and see how you go. We have a graduated process of exposing the joint to a much higher type of loading, and that's tendon, muscle, and joint load, to be fair, that enables them to transition that process to running. And then actually that running component sits much closer to return to sport. So we kind of sort of shift the paradigm a bit, where instead of that 0-3 month time period where you just acute management to running and then a big long gap typically to return to sport, we actually take a lot of that acute management, hypertrophy training, strength training, building up a lot of their motor patterns in terms of movement, then let them run or process of running, and then let them go back to training and to sport. And that tiered process still is around the same time frame.
And so I know every case is different, and I've got to develop that level of strength that you're talking about. But what have you found? So on average, what sort of time frame post-operative ACL reconstruction are your patients starting to run? Would you say on average?
Probably around the 6 to 8 months. Yeah.
6 months for return to running.
Yeah, maybe longer even. And the reason we do that is because we push them pretty hard in terms of getting back a lot of their strength. And actually, I think this is the next big thing. Physios traditionally think they're giving strength training when they're not actually giving strength training. So if we go back to, and just not enough load. Okay.
Not enough load. Yeah.
So are they actually in some way measuring what their maximal capacity is of that tissue? And then are they prescribing at your standardized strength dosage at a sufficient intensity of their 1 or 3 RM, whatever it might be that you've measured, and actually pushing heavy enough load then in big movements? So like triple extension, are they pushing at least 2.5 times body weight on a leg press? Like we've got to get some substantial load through that joint, because if you don't, we argue that your tendon hasn't had a chance to adapt to the type of stiffness and loading you're going to ask in running. You have cartilage adaptation, bone adaptation as well, and then obviously the muscle component. So you're actually preparing it for some serious mechanical load that I think for a lot of people, they don't probably appreciate the actual transition from walking to running. They just think of it as an event, that it's a part of the process and we just give it a go and see how it works out. When in reality, you've actually got a substantial mechanical change in the loading across those tissues when you ask someone to go from walk to run. And then let alone start changing direction and playing sport and thinking about a game or whatever. So again, we try to take that process of probably at least 6 to 8 months, because really it takes us 3 months to get the joint happy, so to speak, quiet, starting to load regularly, getting a pattern in terms of the gym, and confidence back in the knee, and I guess all your gait analysis would come with that as well. And then it's at least another 12 weeks, 16 weeks of strength programming, which I think a lot of strength and conditioning experts would know and agree with. for strength adaptation, you're going to need at least 12 weeks.
Yeah. So you said the leg press is some of your favorite exercises. What other, just for listeners out there who are maybe rehabbing their own knee, what are some of your key exercises that your go-tos? Obviously, it's dependent on your testing and the stage post-op and the state of the knee, but what are some of your sort of favourites for post-op ACL rehab in that sort of 12 to 3 to 6 month post-op? You mentioned the leg press. You're doing those two-footed or single?
Yes, I guess it comes down to what are you trying to achieve in that period. But as an overview, I guess we break it down to be little. What does the athlete need in an ACL population moving forwards? They need to be able to move serious load in triple extension. So hip extension, knee extension, ankle dorsal, plantar flexion. Sorry.
Yep.
They need to coordinate that pattern appropriately. So, and that is a bit more of a qualitative analysis, right? We don't actually measure that. We just have we look at the way they're performing that, and we, through a lot of networks we've worked with as well, we've learned, I guess, this optimal pattern of what does triple extension look like. So do they align the trunk? Do they smoothly recruit that muscle pattern, or are they adapting in some way to just get the load to move? And so in that respect, yes, your leg press is a basic, really basic, but heavy way you can get some load into that triple extension, whether it's incline, horizontal press. We probably prefer a horizontal press because you get a bit more knee flexion in that horizontal phase, whereas an incline leg press, you get a bit more hip dominance.
Easy to get into as well.
Yeah, correct. Sleds are a big one. So we really love sleds, but the key with sleds is not to let your foot drop down into dorsiflexion. I think a lot of people actually, they let that calf drop. So you got to really train at that foot stiffness, because again, that's coming back to function when they run and change direction, is they've got to have enough load in that first to second MTP, and then stiffness in the calf. And as they push horizontally, so we have it sort of in that standardized sled position, that they're coordinating that push from hip, knee, ankle without changing trunk position, hip position, and they're getting that nice long extension. Then your standardized stuff would also be, so for triple extension, like split squats, but I guess the weight, like whether we do split stance squats or Bulgarian split squat, they're all, I guess, routine exercises people would use.
Yep.
I think the main thing comes down to how you train it. I think a lot of the time clinicians will have the right exercises, but mechanically actually haven't thought about the position that they've put the patient in, and the way the patient adapts to that load will be different, meaning they will try to bias a different muscle group depending on what strength they've got in different areas and how they can perform it best. Whereas we take the approach of, if it's a Bulgarian split squat, you need to share that load between hip, knee, and ankle, not just the standard sort of very upright trunk, dropping down, knee down to the floor, because that's going to change the load on the hip relative to the knee. We actually try to shift that so they get a bit more of that shared sort of loading pattern between trunk flexion, hip flexion, knee flexion, ankle dorsiflexion. And she get them to actually load down. It's a bit like a spring mechanics through that front foot, rather than offloading, which is the thing a lot of people do with their Bulgarian, is they have a lot of load on the back leg, and they shift back off it, and they just drop straight down to the floor with a very upright trunk. That'll give you a lot of quad load. Yeah, it gives you a lot of quad load, which is why you can get pretty good quadricep recruitment and, I guess, rehab long term. I think people do this reasonably well. What we find is that calf, hamstring, and hip, though, are way, way underdone compared to what they should be. And that's, again, probably why I think partly people have recurrent knee pain and swelling and issues when they are returning to run.
Yep. Oh, interesting. And what about the low amplitude plyometrics on return to running? You're doing a lot of those in your clinic in that sort of 3 to 6 month phase?
Again, probably not. I mean, I've only had a few patients that are probably ready for that kind of stuff at sort of that 3 to 4, 5 months phase. They have to be pretty robust there, and they're the patients that, again, they might be quite athletic, come from a pretty good background from a strength perspective, and actually have the capacity in the tissue to be able to do those exercises. But if we were to introduce them, again, it's varied, I guess, the way we do this. We don't tend to use the sort of standardized approach that you'll see in some of the guides. We tend to go from a motor patterning point of view with return to running. So we might do sort of a lot of single leg hopping stuff that I'm sure plenty of people would do, but we teach a lot of stiffness. So because the one thing that's different with plyometric type of work is the ground reaction force is going to be far higher in magnitude. And the response is essentially tendon and muscle stiffness to prevent the joint from collapsing. What we find, though, is that motor pattern is dysregulated in a lot of ACL patients, meaning that they either are way too stiff and they lock the knee, or they're too compliant and they basically too springy. And so it's getting that balance of what does a smooth motor pattern look like? And so that's where we might incorporate simply it's kind of like a Bulgarian split squat position, for example, getting them to jump, like hop up and down off a box, like in a sagittal plane first, and get that pattern really smooth. And we might use a metronome for this, because metronomes are really good for cueing that auditory aspect of the brain. A lot of this comes out of the tendon research, but it works really well in rehab of ACLs as well, because it coordinates the right firing pattern. I'm sure you've had a patient where you're trying to teach them something and they just, from a motor perspective, they can't get it. Try it with a metronome, because it changes the way that they pattern, because they actually then can try to start to keep up with the auditory cue, and you can start to speed that up. So you might start as low as 80 beats a minute, and you start to speed it up to 120, 130. So you get into start to move at a frequency now, which is representative of running. So we would do things like that. So sagittal plane is the first thing. We don't do multi-directional. Once they nail sagittal plane, so it might be forward hopping, as I've said, single leg. It could be sort of on the spot, sort of essentially running on the spot. Could be skipping on the spot to that auditory cueing and getting that ankle reflex, getting it really fast off the ground and smooth. And then left, right. So not just doing not a pogo, but like a regular skipping to sort of high knee, legs coming up and down. Smooth patterns on left and right. It doesn't look too different at the right metronome beat of 120 beats and upwards. And then we start to move into sort of sideways movement. So we sort of approach this a bit more like your zigzags. It's like a 45-degree zigzags. We start to get patients to move not so much as a cutting related movement, but we get them to sort of learn to brake and then learn to propel. So it's more as this segmented of brake, propel in a very staged way. We then speed that up, and then we program more of their running technique. So to summarize, I guess we don't really use a lot of the standardized plyometrics. It's not to say that they're not useful. It's just that we come from a bit more of a running background and break down a role of your running and change of direction mechanics to sagittal plane, frontal plane, so side to side movement, and then that 45-degree, and then we collate it together towards the end of that rehab block, which might be sort of 6 to 8 weeks, to be honest, of just really getting the motor patterns solid, essentially, because if they can do that, then we find their transition to running so much easier. Like they don't actually have to think about the technique. The pattern's just ingrained in them because they've been doing it for so long.
Yeah, we've been using the metronome a lot more since we did your course back in August as well. I'm finding it really helpful with those, as well as some just standard strengthening exercises and hypertrophy exercises, which is good. And so moving on from the return to run sort of metrics, what about return to sport testing? What do you think of these? Are you using Pitch Ready or some of the standardized return to sport testing metrics? Do you see a lot of value in those, or are you developing your own one, or what are your sort of return to sport testing batteries that you're using, if you are using them?
I think, so this is a bit of a grey area as well, but from our purpose, we go from a strength perspective to check that they haven't lost and that I guess they've retained their strength.
Mm-hmm.
We would then certainly go into a lot of the counter movement jump hopping analysis.
Yep.
And so what would we do? We'd do your double leg counter movement jump, single leg counter movement jump. On the veiled hop test, it's a 10-5 hop test, which is essentially hopping on a force plate vertically. We're a bit controversial here. We don't use any of the triple hop or single leg hop tests and measure them. We've tried to use a force plate you can use a force plate to measure the landing of those tests to see if that's appropriate. The reality is it's quite challenging to set up a triple hop and get them to, and it's also quite dangerous. Because the plates tend to sit up quite high. So to get the patient to confidently land on it, I just think you're asking too much.
Yeah. And
what's the value in it? Have they adapted the way they hop to actually land on the plate is what I second guess as well. So I guess, we use the force plates in that respect to see that, and unfortunately here there's not a lot of data on it, but do they have appropriate power generation in the left and right limb single leg counter movement jump? Do they have a similar stiffness? So we look at a lot of the stiffness measurements that come out of the valve force decks for the single leg hopping, because we want to make sure that they're actually similar. And the one thing we do that's probably different to a lot of people is we use a metronome for that. And the reason we do that is because we want to standardize left and right.
This is a single leg counter movement jump.
Yeah. So
patients got their hands on their hips, so
hands on hips, vertical hopping, and try to keep them at that. You can do it at 110, 120, you can go higher. If it gets too high, it becomes too fast for that type of task, though. And essentially, we're just trying to analyze from a motor, partly strength perspective, can they perform that motor pattern at sufficient stiffness, left versus right? That's all you're looking from it. There's arguments that the beats per minute is too slow for running and return to sport, and that's true. But we just don't have the technology to be able to do that robustly unless you're in a bigger lab environment. So I guess that's the best test, to be honest, for that vertical component of single leg stiffness.
And which outcome metric are you looking for as a measure of stiffness?
So there's literally a measurement in the valve force decks hub or on the app that gives you a stiffness measure in newtons per meter. I'm pretty sure it gives out. So to show you, it's this arbitrary number, to be honest. You can't actually have a threshold of what stiffness you want.
Yes.
Based off the decks, but you can certainly compare. That's the only one we tend to do is asymmetry.
Yeah.
What's left versus right like in that hopping task at a certain frequency, and what happens if we change the frequency? So if you go faster or slower, are they able to adapt? And that's what we look for in sort of that specific test.
And you want patients to be pretty close to symmetrical on that metric before they return to sport?
Yeah, we like under 5%. So we go pretty low. Yeah. And it's people say, that obviously the standardized is 10%, but it's very much achievable if you spend the time there to get it under 5%. It's just that I think people sometimes get a bit lazy, or their patients really eager to get back to sport as soon as possible, which I completely understand. And so they let it slide at 10% or 9%, but that's still a reasonable difference of 9 or 10%. So you've still got risk there, and you're just playing with risk when they've got more of a difference between sides.
Yep. Yeah. And so the way you're rehabbing ACLs at the moment, sort of the return to sport used to be 6 months and sort of been pushed out to 9 months and now out to 12 months. What's your sort of opinion, and what have you found in your clinic? How long is it taking people to get to return to full level sport?
I think 12 months is certainly the standardized time frame, but we've had people wait till 18 months, to be honest. And there's actually quite a bit of evidence to support 18 months. It's just that athletes or patients don't really want to do it because they want to get back to sport.
Yes.
And the reason is that the maturation of the cartilage and the graft is actually better at 18 months. So it actually takes a substantial amount of time to get a lot of that remodeling in the bone, a lot of the cartilage, like the initial insult from the ACL rupture, the cartilage remodeling, the bone edema to really, really settle. For a lot of patients, it's actually sort of past the 12-month period that it's actually back to somewhere near pre-injury levels. So that's not to say you have to wait that long, but I think 12 months is the absolute minimum.
Interesting.
But again, we have the time as sort of, if I think about your checklist, it's probably at the bottom, to be honest, meaning we make sure that all their tests we've talked about, so their strength, the clinical signs, so whether they've got swelling, obviously their range, we might do a pivot shift and some of their instability tests to make sure that they're still fine. Their counter movement jumps, as we've talked about in terms of performance. They're back at training. We also screen their fear avoidance. So ACL RSI is a good one, but looking at the psychology of whether they're ready to return. And if it's all looking really good, then have they hit from a time perspective that 12-month period? And if they have, great. If they were at 9 months, though, I'd probably still hold them back a bit, just simply because of the nature of the maturation of the graft and bone healing, etc., is still happening and an evolving process. And it's, I guess from a lot of the research, it's multifactorial, but people are a little more likely to re-injure when they go back earlier. So, 12 months is typically the period of time we use.
That's good, great info. I do wonder if it'll change from what's already changed from 6 to 9 to 12, and whether it'll change to 12 to 18.
It might, but I think then again, I don't see how athletes will probably accept that, and whether like clubs at a professional level can't have an athlete out for 18 months. Like they just, it's this conundrum between what's the best for your health outcome versus what's best for performance. And for them, in this respect, they don't actually meet together. They're actually poles apart.
Particularly in a professional sport, which is, I mean, we've got to remember that's a tiny percentage of the population, but because it's high profile, tends to carry the most weight, I guess. But things are done quite differently for a number of reasons in when you bring in that professionalism aspect to it. And what about sort of non-operative management of ACL and return to sport? Can these people who decide maybe not to have surgery, but they do want to go back to sport, whether it's with or without a bracing protocol, are you managing many of those patients? And have you seen that they're getting back to sport on a different time frame, or is it taking them a long time to return to sport, or you're just not recommending anyone to return to sport, say with an ACL deficient knee? Or
I guess from our perspective, we don't. I've got plenty of non-operative or conservative, however you want to describe it, patients, but we don't tend to see a lot that go, like, for example, the cross-bracing protocol, that pathway. I'll be honest, we don't do a lot of that, and that's not out of neglect or anything like that. It's simply due to the type of patients that we see, to be honest. We tend to see a bit more of an athletic population, which in most cases, given that they've either got repetitive instability episodes or are pursuing a professional career, in most cases, the sort of bracing protocol is probably not going to be appropriate. I know you can do it because people will probably shout at me to say that you can, and it's feasible, certainly. But I think in the population we see, we don't tend to do a lot of non-operative management, other than your sort of office worker that we'd see in the city that's pursuing a recreational lifestyle. For sure, we would manage non-operatively, or it might be a partial strain of the ACL, and we certainly leave it as is and don't recommend surgery necessarily. We would just push them down more of the functional pathway of improving their strength and coordination, power, all those aspects we talked about.
And those people who've got partial sprains or aren't interested in going through surgery, have you got many of those returning to ball sports, or say?
Yep. I mean, it's often quite fascinating how many people can get back to function completely fine. And I think the whole notion around surgery or non-surgery comes down to, for me anyway, the instability episodes, really. It's not that you can't go back to sport. It's more a question of what sport are you going to participate in and what's the function of your knee like. So if you've got two different patients, one with really good strength of the muscles we've talked about, hip, knee, ankle, a really good movement quality and pattern. So they've got sort of this athletically gifted person, let's say, that's come from an athletic background, has an ACL injury, wants to get back to sport, has no or minimal instability signs, swelling within the joint. There's an argument to say that there's no reason to go down an ACL path, a reconstructive pathway. They might have a meniscal episode though later on, because they're actually at higher risk of meniscal injury, which will then likely lead them into the operating room, in which case then they'll likely get the ACL reconstruction. But that's just the risk that you weigh up with the team or the individual at the time. On the other side though, if you've got someone who's deconditioned, for example, and has no instability signs, then you really should focus on a lot of the strength aspects first. See how you go, and then I guess that process would evolve with it. If they don't have instability signs, continue. If they develop instability signs, then that might be the operative candidate.
Those instability signs normally, well, I guess patients are kind of feeling like they need to make the decision, surgery or non-surgery, quite early on post-injury. They're seeing surgeons straight away in the first few weeks, and they're weighing up, bracing protocol versus not bracing protocol. So, and their knees functioning pretty low level at that time, so they're probably not exposing it to the type of instability that might cause an instability episode. So, how are you sort of advising? What sort of conversations are you having to those patients in your clinic who might have ruptured their ACL within the last few weeks? They haven't had any instability episodes. What's sort of speaking about with those patients?
I think you need to establish what is instability episodes, because people don't know. So for physios, they obviously recognize that it's more of that giving way, buckling, feeling like it's going to collapse on them, however they might describe it. So I ask patients about that. So do you have episodes getting out of a chair? It could be crossing the road. I've had patients that literally try to step up onto a gutter or get out of a taxi or a car, walking down the street, pivot, turn to say hello to someone. It's more that daily function first. Do they have episodes? And then it's how frequent, because it's not as though you have an episode, you should get surgery. It's about the frequency. So if they have multiple episodes per week, and that's increasing to daily, then I would start to think this might be a much more candidate for surgical pathway, because it's unlikely that's going to resolve.
At what stage post-injury are you talking about there?
Yeah, so normally that would not occur in the first week or 2 weeks after injury. You would let that evolve, because I was going to say is, I wouldn't then go straight to surgery though, if they've been having multiple episodes of giving way and they're really deconditioned, because we know you then put them into an operative room and come out post-operatively deconditioned with a reconstruction. They're going to be pretty hard to rehab.
Yeah.
And long-term, they're probably not going to have a great outcome. So we would try to do our best to control the instability episodes and get their strength, the coordination, and I guess the movement patterns as best we can. This is where you might use something like a brace to help with the instability episodes, and then make the decision or the discussion around, okay, are we going to go down an operative pathway? My suggestion would probably be, if it's happening daily, it's unlikely to change, especially if you want to pursue change of direction sports.
Yep.
And I guess that's more of the informed decision, shared decision-making process that people talk about then. That might occur though at it could be 2 months, 3 months down the pathway, maybe more.
Yep. So most of your patients are waiting that 2-3 months post injury before having surgery these days, or are you finding people just want to jump in and have it done as soon as possible? Or?
Yeah, it depends really, because sometimes they don't come to us directly from the injury, right? They might go immediately to the orthopedic surgeon, or they've gone to the GP and the GP sees ACL rupture and refers them straight away to the surgeon, and the surgeon's then happy to open it up and do it. So I guess if it comes into our hands as a sort of primary contact and we see it and can advise on it, then sure, we'd likely give them a guidance on, let's wait, get this right, because often they're not informed by a lot of GPs around your prehab kind of world, and I guess letting the knee settle and getting it to an established level before surgery, if that's the pathway. And they're not really informed so much about conservative management. So I guess depends upon which way the patient enters the medical system in a way, and which way they're sort of deviated, whether it's surgeon or us, or if it's neither.
Yeah, and then Australia does have one of the highest surgery rates for ACL ruptures in the world. Are you still sort of seeing that in Melbourne? I know each market has kind of got its own nuances, I guess. But what's the kind of current state of play in your market? Is most people still going for surgery post the ACL rupture, or have you noticed any change in the last few years?
No, I think it's. I mean, again, it's a bit biased from my perspective because we see a lot of athletic people.
Yes.
I think as a ballpark, I probably have of all the ACL patients, 10 to 15% are probably what you define as your recreational office worker type of rupture.
Yeah.
So they did it at a casual game somewhere. The bulk are in either a sub-elite or elite sport, and 99% are reconstruction. So
already,
that definitely sort of is true. Is that the reconstruction side of things is probably the most popular by far, and that's probably partly also a product of media attention to it as well. So, and surgical recommendations, and the notion of how you manage an ACL injury from a medical point of view. I doubt many medical professionals would know about your cross-bracing protocol and conservative management if you were to actually survey a lot of them across Australia, even internationally. I think you'd find there'd be a very, very small percentage that are actually aware of the fact that you can heal ACLs or do these other things with ACL management.
Yeah, I guess your clinic's quite different to mine in that we're in an expat services market as well as so your expats tend to be over 30, 35. They're not really playing. There's not much high level sport for expats, I guess. Most of them are playing social sports and more focused on their career than their athletic outcomes. And that sort of future sporting goal tends to be the number one factor in deciding whether to operate or not, I guess.
Yep, exactly right. So it just comes down to your proportion of patients, so a population.
Have you been keeping an eye on the cross-bracing protocol, and have you got any opinions on that, or have you seen any that? Or
I've obviously, I'm very much aware of it. Obviously, I've read the paper. I've heard from Jane Rooney about it. I was at a presentation she did a few months ago. Now, what do I think about it? I think it's fascinating from a physiology point of view.
Mm-hmm.
I'm still cautious though from an outcome point of view, and I think before people jump on it too much, it's not that you shouldn't be doing it. It's just that I think long term, like I think Steph Fieldbay would probably admit this as well, is that we don't know what long term is going to be like, which they'll be doing, I'm sure.
Yeah.
I still, irrespective of whether it's cross-bracing protocol, whether it's non-operative without the cross-bracing protocol, or if it's surgery.
Yep.
My big thing with ACL management is we still don't have rehab timelines and goals and objective criteria. So if you zoom out from the big picture of ACL injury, a lot of the research and literature is focused on two areas. ACL management initially, so operative techniques
Yep.
and management, so non-operative or operative. Cross-bracing protocol obviously sits within that.
Yep.
And return to sport.
Yep.
Like that's your two paradigms, right? The problem is, if you think about the longest stage in rehab, it's rehab, meaning it's the time after your surgery or your bracing period the bracing period where you are unrestricted, if you're doing the cross-bracing protocol.
Yep.
And it's that time period right up until the point where, let's say 12 months, you think you're ready to return to sport. The biggest problem is we're not actually measuring, and there's not a lot of good research to support what you should be doing here, other than theory and expert opinion.
Yep.
There's not a lot of objective criteria that uses technology, for example, because I think if we did that, that would make the leap from management, of whatever it might be, to return to sport far more successful. The problem is we medicalize it as, should we brace it? Should we do surgery on it? And then there's this polar opposite end of mainly physio sports scientists and S&C experts that look at what do we use to return to sport. So I think the bigger question should be, yes, we might look at the cross-bracing protocol or ACL reco, but it should also be looking at how that evolves if we were to pursue different rehab pathways. Because a lot of that's not been done. And I know for a fact that if you look at a lot of the studies that have been done in RCTs of exercise prescription or different interventions in an ACL population, a lot of the prescription's pretty poor, to be honest.
Yes.
It's not actually true strength training. It's not actually individualizing that approach for a patient. So they're not actually measuring which patient has, for example, reduced capacity of their calf, because some have reduced calf, some have reduced hamstring, some have reduced hip. They're just blanketing the approach essentially with, let's do this protocol and see if this protocol is better than this protocol. That's probably the bigger issue, I think.
Yeah, that individualized exercise prescription being the
and I guess and the quantitative or the objective measurement throughout the process, and what benchmarks we should probably have people at to allow them to proceed to a next phase or progression in their exercise, and not just measuring off asymmetry, which is a lot of what's been done.
Yeah. Sounds like a good job for you, Tim, to develop that those benchmarks.
It's a lot of work.
I can imagine. Yeah.
Yeah.
All right. We'll probably wind it up there, Tim. That's been terrific for our listeners and for myself. It's always great to listen to you talk and talk about tech in physiotherapy and rehab. It's really, from a personal perspective, it's given me a new lease on life in my new sort of invigoration. And I think there's more and more physios around the world who, particularly guys like me, who've been at it for 25 years, you can kind of get a little bit stale, I guess. So it's great to see the progression of the profession and people like you really pushing the boundaries and trying to make the whole profession better and better. So I hope not only the general public that listen to this, but also the physiotherapists can get some great messages to take home in their clinical practice, and we can all provide a bit better service for our patients and keep pushing the progression of the profession forwards.
Well, thank you very much. It's been great to have a chat, and I hope it's helped people to implement tech, because I think it's the pathway to the future with physio, and it'll only evolve from here on in.
Yeah, awesome. Thank you very much, Tim.
Pleasure. Thanks, Bevan.
The Knee Gurus, brought to you by Asia Physio, providing world-class physiotherapy care across Asia. Visit our clinics in Tokyo, Singapore, Niseko, Hakuba, Nozawa and Myokokogen.